Our patient was a 40-year-old, previously healthy American male with no significant past medical history. He presented to the clinic after completing a 6-month work assignment in Nigeria and returning to the United States. Throughout his entire time in the endemic region, he had taken no travel chemoprophylaxis. His illness began precisely 10 days after his return flight. The initial symptoms were vague: fatigue, vomiting, and diarrhea. He visited a local clinic, received symptomatic treatment, and was discharged home. 4 days later, his clinical picture worsened violently. He developed severe chills, progressive weakness, visible jaundice, and a sharp decrease in urine output. The most alarming clinical sign was a dangerous fever, spiking to 40 degrees Celsius. This chart tracks his body temperature over time. The fever did not hold steady. It peaked at 40 degrees, broke, and returned exactly every 48 hours. A fever with this exact, rigid regularity points away from typical bacterial or viral respiratory infections. It indicates an aggressive biological cycle operating directly inside the bloodstream. The patient was admitted through the emergency department directly into a specialized isolation ward. The clinical team immediately suspected a vector-borne infectious disease. His admission vital signs showed systemic physical stress. He was hypotensive with a blood pressure of 95/60, tachycardic at 120 beats per minute, and mildly hypoxic, saturating at 93% on room air. Outward vitals only capture surface-level compensation. They fail to illustrate the actual severity of the physiological collapse occurring at the cellular level. To map the extent of the internal organ damage, the attending physicians ordered a comprehensive laboratory evaluation. It covered 4 major categories: hematology, hepatic function, renal function, and systemic inflammation. This matrix shows the hematology panel. A normal WBC count of 5.8 provides false security. Hemoglobin is dangerously low at 7.0. The normocytic anemia and elevated RDW indicate sudden cell loss. Platelets collapsed to 48,000, and LDH spiked, signaling severe active cellular destruction. The hepatic panel explained his visible jaundice. Liver enzymes AST and ALT were elevated to 265 and 243. Total bilirubin reached 12.4, revealing massive red cell breakdown overwhelming the liver's processing capacity. The renal panel confirmed acute kidney injury. His estimated glomerular filtration rate was severely decreased, driving his creatinine to 2.49, accompanied by metabolic acidosis. The combined triad of severe anemia, elevated LDH, and profound thrombocytopenia, paired with liver and kidney dysfunction, confirms a massive, unified intravascular destructive event. This clinical matrix organizes the differential diagnosis for a febrile traveler returning from West Africa.
Dengue and yellow fever are deprioritized because the patient lacks retroorbital pain, rash, or active bleeding tendencies. Typhoid and leptospirosis remain due to GI symptoms and kidney injury, but neither aligns with a 48-hour cyclical fever. Matching the triad of cyclical fever, hemolysis, and severe thrombocytopenia isolates malaria as the primary target. Targeted rule-out testing for the mimics will continue, but malaria is now the definitive clinical concern guiding immediate intervention. Diagnosing malaria relies on 3 primary laboratory tools: rapid diagnostic tests, polymerase chain reaction, and optical microscopy. Optical microscopy remains the traditional gold standard. It allows the pathologist to confirm the Plasmodium species and quantify the percentage of infected red blood cells. This is a micrograph of the patient's thin blood smear. Inside the central red blood cell, you can clearly see multiple, delicate ring-formed trophozoites. The smear also revealed applique forms, parasites that appear physically attached to the inner edges of the host cell membrane. Notice that the infected red blood cells remain normal in overall size. Other Plasmodium species, like Vivax and Ovale, visibly enlarge the host cell. The presence of classic crescent-shaped gametocytes in the peripheral blood confirms the specific morphology of Plasmodium falciparum. The thin smear showed a total parasitemia of 16%. This extremely high parasite burden dictates that this is severe, life-threatening falciparum malaria. The infection begins when an infected Anopheles mosquito bites a human host, injecting sporozoites directly into the bloodstream. Why does Plasmodium falciparum cause such disproportionate lethality compared to other malaria species? Unlike other species, falciparum invades red blood cells at all developmental stages, allowing massive multiplication. Once infected, cells undergo cytoadherence, binding firmly to small capillaries. This is followed by rosetting. Infected cells bind to healthy ones, creating clusters that entirely obstruct the microcirculation. With the capillaries blocked, the surrounding tissues are starved of oxygen. This microvascular blockade directly causes the tissue hypoxia, acute kidney injury, and metabolic acidosis evident in the patient's lab results. The accumulated data forces a unified conclusion: imported severe falciparum malaria with hyperparasitemia. Hyperparasitemia of this magnitude is an immediate medical emergency, requiring intense and rapid systemic intervention in an ICU setting. The first-line protocol demands intravenous arsenicine. The dosage is strictly scheduled at 0, 12, and 24-hour intervals to rapidly halt parasite replication. The laboratory dictates the pace of the treatment. Thick and thin blood smears must be repeated every 12 to 24 hours to verify the physical clearance of the parasite burden. The medical team can transition the patient to oral therapy only when the parasitemia drops below 1% and internal organ function stabilizes. Surviving the acute infection and breaking the 48-hour fever cycle does not mean the patient is out of danger. Patients face a major delayed complication, post-artesunate delayed hemolysis, or PADH. After the artesunate kills the parasites, the spleen attempts to remove the dead material. The previously infected, now damaged red blood cells remain in circulation and rupture days or weeks after initial discharge. The patient requires continuous monitoring for hypoglycemia and clinical recrudescence to guarantee the biological threat is permanently eradicated. For clinicians evaluating a returning traveler, the diagnostic imperative is clear: never dismiss a rigidly repeating symptom profile. A cyclical fever is a biological clock. Recognizing its rhythm immediately dictates the difference between a routine recovery and catastrophic multi-organ failure.